the question has been brought to me, how dangerous is formalin? Because it says causes cancer in California. Well, it is a VOC, a volatile organic compound. So use proper PPE, gloves, goggles. If you're wearing scrubs or an apron, that's enough. The big problem with formalin is when it gets aerosolized, so if it gets heated up, it's the vapor, it's the fumes that are gonna get you. And yeah, the most thing it's causing is lung cancer. So not to scare you, we work with it every single day. All of your ORs are vented, environmental control exchanges the air. They do that in my room all the time. So now I understand you just took a specimen out of the OR. You have to walk through the clean hallway. You get it to surgical pathology, and we want you to put formalin on it. We provide gloves. We have goggles in there. We have all the PPE that you need in order to put chemicals on our tissue. We also ask that if you do put formalin on tissue, and not everybody, I guess, has been told this, we ask you to label it what you put on the tissue. So if you're putting saline on tissue, you know, mark on the side of it that it's got saline. If it's formalin, we have this. We have other solutions that actually are for fixing tissue as well. I doubt you'll deal with many other than, say, normal buffered saline and formalin. But if you do put something on the tissue, let us know so we know how to properly handle it. Formalin, this is just for your information. We pour down the sink. And that's how we get rid of formalin around here. And you're wondering, why do we do that if it is this terrible compound that can cause cancer in California? Well, in California, yeah.
Only in California.
The University of Missouri was established before the EPA, and we're a land-grant university. And so the rules of the EPA don't always apply to the university. And so when there is cost-saving matters, like should we capture the formalin and neutralize it first, or if we can just dump it down the sink and use water to neutralize it, the university has chosen the latter. So, there are other substances, alcohols, acids that we use on our tissue that we do have to capture and that we can't pour down the sink because they're going to corrode pipes, they're going to cause problems downstream. But formalin, with the university, has said that that's the acceptable way of disposing of it. I see a hand already.
What are the costs to the patient of the little containers with the lids on them? Sometimes if we put something in a medium or a large cup, you see people open 4 or 5 small containers instead of going to the lab to pour a substantial amount of formalin on it. Is it actually cost effective to open 5 small containers and pour it in there versus taking it to the lab or calling a tech? Because it's not always feasible if a nurse is in a big case, leaving the patient to take it to the lab. And you know, if we call an anesthesia tech for that, are we upsetting the apple cart? So what's cost effective?
Cost effective would of course be to provide it from a larger container, and we've got 5-gallon containers. It's also resource savvy in order to use from one source versus to use a bunch of little ones and throw away the plastic because we're not recycling the plastic. That's me being a tree hugger there. The cost is no different for the patient because we're not charging per container. And the formalin containers that you're using are being purchased by our department. So.
With mammography, they put them in those blue specimen containers downstairs, the actual.
Mm-hmm.
Do you guys accept those, or do you want them transferred over, or what's?
We do accept those. We hate those because the lids don't fit on very tight, and so when we do put a liquid on there, if there is any jostling, it does tend to spill more. But no, we do accept those containers, and we may later transfer them out of that container into a more suitable container. But it's got a grid on it. It's great for doing the x-ray before it comes to us.
don't forget to add in there that if we take it to El Shell, it needs 3 stickers on it. Instead 2 for all those nurses out there.
We're getting to that, yes.
Okay.
So proper labeling of specimens. I guess we can jump right ahead to that. How do we like to receive specimens? And if you're in the OR room, most of the time they ask you to do 2 labels on it, and the label's gonna have, of course, name, date, and initials across the bottom. There's spots for that on every one of the IDX labels. And then we ask you to write in the tissue source. Helps us know what part it belongs to, especially if you have a multi-part case. And as you said, 3 labels, because Ellis Fischel is going to take one of those labels for their records. We don't require you to have 2 labels. One's fine, but then we ask whoever brings it over to our lab, write all that information down in the log. So it is benefit to whoever it is, whether it's being anesthesia tech that's bringing it over, one of the nurses. You want to get back to that room. You're not doing yourself any favors having to stand there and write information in like medical record numbers, full patient name, date of birth, so we have a record of it. If you can slap an IDX label on it, it's going to save you time. This is our requisition for surgical pathology. It's got 11 spots on it on the front sheet. It is a 3-part form. So it's got yellow and pink carbon copies. So when you write on one, if you're using a pen, not a marker, and you press firm, it should go all the way through to all 3. If you only have 1 specimen or you're not sending a frozen section, that's great. You don't have to do anything extra with this form. You just send it along with the specimen. We do ask you not to write in one little space up here. There's one box that says for lab use only. Try not to put 15 specimens on this. If you need 15, grab 2 forms. Makes it easier for us. I don't know why they went with 11 spots. I guess it's what fit on the form. But if you are going to do a frozen section, and some of you will do frozen sections from your OR room, we ask that you send the pink copy with the first frozen section that comes to us. And it should be listed on there. And then if you have to send a second frozen section, again, 3-part form, you can send the yellow copy. Now, if you need to send a 3rd frozen section, and some people do, we just had Dr. Dooley send 20 frozen sections the other day. Somebody got that room. The 3rd frozen section, you're gonna go with another form. And these forms, again, provided by our department, don't cost you guys anything. Send the pink copy again with the 3rd one. Now, if you send 3 all at once, again, it can all be on one form. But the second set that you send, say you send 8 more, you know, that can be all on that second one. Dr. Dooley sent 12 at once and sent 2 forms with it. And all that is explained on the back, this nice kind of color-coded area right here in this form for you guys.
We need stickers for each frozen, or is that for like a set of
Per each frozen, per each tissue part. So if you have 12, you're gonna have 24 stickers. So, I know.
I mean, wait, if you have 3 specimens, you'll have 24 stickers, right?
No, I said 12.
12? Oh.
2 stickers per each. That's to save you guys some time. Okay.
The 6 stickers we send separate.
Oh, for a frozen section, we ask for 6 additional stickers, and that's for us, our labeling process, because we then grab another form, and it's a form that's an interoperative consult form. It's another 3-part form, plus we document in other books that we received it when we received it. And some of the docs, like Dr. Zich, want us to actually send back the pink copy, and some of you have seen it. If this goes back to you guys, and it's not this form, it's a form, it's the interoperative consult form, that's to go in the patient's chart. And I guess we're still using old 3-ring binders with patient charts, and that's where it would go. That's to relay our doctor's diagnosis back to the surgeon.
So it's not 6 stickers per, it's 6 stickers per set, not
Correct.
per, okay. I was gonna say,
Per set.
20 frozen, there's no way.
So now I want to answer the thorny question. What's the difference in between fresh, frozen, and permanent? And a lot of you were in my talk about 2 months ago, and so hopefully you have a good idea of fresh, frozen, and permanent. And then of course we're going to throw microbiology in there as well. What do we do with that? But a fresh specimen, and some of our surgeons have different thoughts than what the lab's going to tell you. So I'm going to tell you what our interpretation is for a fresh specimen. That means the specimen came out of the body, it comes to us, and something needs to be done with it before we put any solutions on it, aside from saline to just keep it moist and wet. Now we could be doing a lymphoma workup. We might be needing to take cultures for microbiology. We might be doing a frozen section on it. So if it comes out fresh, we're going to do something with that tissue. Yesterday we had Dr. Stavelio Carroll send out a lobe of liver, and he wanted it sent fresh. He didn't want a frozen section on it. He needed us to do gross margins. So we sliced it all up for him, and he came in and stood over our shoulder the entire time. And we looked at the distance in between that tumor and his cauterized margin. And we asked him not to do this in the OR. And you'll probably find plenty of surgeons actually open specimens in the OR for their own benefit. But in cases like that, it does disrupt a margin. Now, with Stavelio Carroll in the room with us, we had inked the specimen before he got there, so we had clearly demarcated any of our margins. And then when we cut it in the fashion that we need in order to get sections later to show the relationships. Not all the surgeons are going to do that when they open the specimen. They know the proper way for us, and for us to give a proper staging later. A great example, not to say anybody's bad or not, but Dr. Toller and Dr. Hunter like to open uterus specimens. And when they do that, they do disrupt margins. We need to be taking soft tissue around the cervix for staging purposes. And if you open up a cancerous uterus, if you've got a friable tumor, and most tumors can be friable, gets into that soft tissue, we're going to upstage a patient. Just because they were curious. Now we're going to say that there is tumor outside of the uterus, which makes you from like a T1 to a T3, and it's a lot of consequences for that patient. They might have to go through extra chemotherapy. They might get localized radiation therapy now because of the higher staging, because our surgeon was curious. So what we'll do is when we get a specimen that's intact, we'll take that soft tissue off first, we'll ink the specimen, then we'll open it, and then later if we see a tumor that's on the ink, like on top of the ink, we know that that's artifact. But if the tumor is under the ink, we know that that's true. And so that's how we'll be able to stage them better. I do have a question.
Have you talked to Dr. Toller and Dr. Hunter about that?
The answer is no, I personally haven't, and some of my pathologists that I work